Thank you, League of Women Voters, Kate, for inviting me. I don't do talks like this, never done this. I'm a family doc. I get out of the office, ran home, stuffed something into my mouth, and got in the car. This talk is a compilation of articles, speaking with a lot of people, and probably most importantly, my 32 years as a family doc. I'm a family doctor. I will listen to you, treat your diseases, help your pain, do home visits, and respect your right to refuse treatment. I will not help you or anyone commit suicide or kill you. I just want to review a couple of definitions. Suicide, the act or instance of taking one's own life voluntarily and intentionally. Physician-assisted suicide, when a physician facilitates the patient's death by providing the necessary means and or information to enable the patient to perform the life-ending act. Euthanasia, an action or omission that of itself or by intention causes death in order to alleviate suffering. For thousands of years, doctors have been guided by the Hippocratic Oath that states, "I will neither give a deadly drug to anybody who asked for it, nor will I make a suggestion to this effect." Assisted suicide is fundamentally incompatible with my role as a healer to do no harm. It's the ultimate abandonment of patients. Allowing doctors to assist in killing threatens to corrupt the profession of medicine. I've taken care of patients for over 30 years. I've counseled them through many difficulties, and they have grown to trust me. For me to assist a patient in their suicide would undermine the trust and respect society has grown to expect from physicians. I could not ethically treat one patient while assisting another to commit suicide. People with serious illnesses will become fearful of the motives of doctors and insurance companies. The rising cost of medical care, not compassion for the dying, is driving the promotion of assisted suicide and euthanasia. Insurance companies realize it's more cost-effective to allow someone to commit suicide than to take care of them. This is a reality in Oregon and California, where patients have seen that their chemotherapy treatments were not covered, but drugs to commit suicide were. Just as insurance companies have manipulated patients' medicines by controlling co-pays, so too will they pressure doctors, patients, and families to take the least expensive treatment available, suicide, if it is legal. Some say it's all about not letting anyone take our choices away. As a colleague of mine said, passing physician-assisted suicide legislation will limit your choices unless you have a yacht to sell to pay for your treatment options that the insurance company decides are too expensive. And almost everything is more expensive than the suicide drugs. That's why they want doctors to be able to prescribe it, so it can be called a treatment. And then they can decide between heart bypass, dialysis, your pacemaker after age 70, or the drugs. The bulk of someone's insurance dollars are spent in the last 6 months of life, exactly the duration that these laws push for. And if you get the pills, we have no idea what will happen to them. When are you going to take them? Will your medical condition have changed before you take the pills? Do you really have less than 6 months to live? What if the doctor's wrong? And as said before, I can tell you any doctor who's seen a number of patients has been wrong at some point in predicting how long you have to live. I have several patients that have lived 5, 10, 15, and one lady 20 years after she was on hospice and told she had less than 6 months to live. If you take the pills, we wouldn't know if you had more than 6 months to live. Will you be competent to take the pills in the future? What if someone is forcing you to take the pills? What if someone else takes your pills? Doesn't it scare you to have these unanswered questions? So what safeguards against abuses exist to prevent impaired judgment, coercion, or undue influence from others with their own selfish motives at the time the decision to take life is actually made? The answer is nothing. If compassion demands that some patients be helped to kill themselves, it makes little sense to claim that only those who are capable of self-administering the deadly drugs be given this option. Should not those who are too disabled to kill themselves have their suffering ended by lethal injection? And what of those who are too disabled to request that their suffering be ended, such as infants or the demented? Should they be denied? There's no way to limit how far the laws will go. Why 6 months? Why not 12? Why just terminal diagnoses? Why not any diagnosis? What if you can't make the diagnosis? How about a proxy? Why not minors? You can't take away the rights of minors. What if the doctor or nurse decides for you? All these have happened in Europe. In Oregon, proponents of assisted suicide insisted that it was needed for patients in intractable pain. But physical pain is cited by only a small minority of patients. The primary reasons are loss of autonomy, loss of dignity, and fear of being a burden to others. It's not about unbearable physical pain. Allowing suicide for one group leads to increased suicide rates for the rest of the population. When vulnerable people see suicide as a good, suicide rates in general rise. In Oregon, suicide rates overall, excluding those from physician-assisted suicide, are now the second highest rate in the country. 95% of those who kill themselves have been shown to have a psychiatric illness, but less than 5.5% of the cases in Oregon were referred for psychiatric evaluation, even though oftentimes treatment of depression alleviates the wish to hasten death. And up to 50% of people in chronic pain are depressed. Brian Johnson, a former California Commissioner on Aging, said the study of Oregon-assisted suicide cases shows that patients were deeply depressed. This is a cry for help, he said. Suicide is the #1 indicator of depression. Instead of writing a lethal prescription, the medical community should address the patient's emotional state, he said. Recently, I saw an elderly patient of mine in the office after having been hospitalized numerous times for Clostridial difficile intestinal infection. Ellen suffered from chronic weakness and asked if there was any way to help end her life sooner. Her husband had passed away several years earlier, and she had one son, Paul, who she rarely saw. Ellen felt that she was being a burden to Paul and thought life would be better for him if she were not around. Further evaluation of her symptoms revealed Ellen was suffering from depression. She agreed to go on a low dose of an antidepressant, and I spoke to Paul, who agreed to come to his mother's follow-up appointment in 2 weeks. The demeanor of both revealed a very cold relationship. When I explained Ellen's request to Paul, he turned to his mother and asked why she would want to end her life. Ellen explained the infrequent contact and thought that he would be happier if she were dead. Although Ellen thought dying with dignity would be the best thing, she didn't realize how this would affect Paul. I encouraged Paul to communicate with his mother and treat her with the dignity she deserved. I set up a follow-up appointment for 2 weeks. When Ellen returned with Paul, their interaction was completely different. Ellen had gained weight and was smiling. Paul was attentive and reviewed with me quality time they had spent together. Ellen no longer wanted to die, and Paul had renewed respect and love for his mother. A few months later, Ellen died of natural causes. Her son was thankful for the time he had with his mother during her last weeks. If someone walks into an emergency room and says they want to kill themselves, they will have a thorough evaluation by a psychiatrist, social worker, and nurses. that will go to any length to save that life. Why is life so important in the emergency room, but worth nothing up on the geriatric ward? We have suicide prevention hotlines, but as we age and acquire age-related disabilities, our lives are not worth living? Why do we have signs on bridges that say life is worth living with a phone number to call to try to prevent people from jumping? There are legal and political and not just ethical prohibitions of racism, slavery, unjust discrimination, and marginalization of women, children, the ill, and disabled people. I feel compelled to mention the disabled because they weren't invited here tonight. Physicians in Oregon already have no punishment for failure to report, no peer review for appropriateness or complications, or if death actually occurred. And physicians are prohibited from putting assisted suicide as a cause of death on the death certificate. I've filled out many death certificates, and there's nothing on there about assisted suicide. It's natural causes, suicide, the immediate cause of death. I don't know if you've seen death certificates. Ed Meckman, attorney, while speaking in New York, stated, "The bills will endanger vulnerable people, will endanger poor people, will endanger isolated people, will hurt mentally ill people, will cause more suicides, will corrupt the medical profession, will corrupt family members, and hurt society." Ed Meckman goes on to outline other pitfalls in the legislation, namely, suicide is defined as a particular instance of a person intentionally killing himself or herself. The proposed legislation wants to change this definition. How can this not be considered suicide? The legislation further states, a patient who requests medication under this article shall not, because of that request, be considered to be a person who is suicidal, and self-administering medication under this article shall not be deemed to be suicidal for any purpose. Why the definition change? It's certainly more appealing to patients who wish to end their life, doctors who may be considering their patients' wishes, and the healthcare industry that looks to save significant money on possible healthcare costs. The legislation goes on to state, a person and his or her beneficiaries shall not be denied benefits under a life insurance policy for actions taken in accordance with this article. This is not really suicide, according to the bill. When will society wake up and realize that suicide is suicide is suicide? If this is truly to be accepted by society, then why is there so much emphasis on suicide prevention today? A verbally engineered redefinition of suicide, and in this case, physician-assisted suicide, will rapidly escalate society down the slippery slope of what becomes legal, is soon accepted as normal, and then thought to be moral. We need to consider how verbal engineering always precedes societal engineering. By calling it a medical aid in dying act, one would not be concerned that there are actually suicide bills. Euphemisms are used here for those matters that people prefer not to deal with directly, thereby sanitizing our debates. How many of you this evening knew what palliative care was before you came here? Palliative care is an option for people of any age at any stage in illness, whether that illness is curable, chronic, or life-threatening. It focuses on the relief from symptoms and stress of the serious illness. Suicide laws don't require palliative care consults, and a good percentage of people change their minds when seeing a palliative care specialist. It doesn't require a waiting period or meaningful doctor-patient relationship. I can tell you a significant amount of change can be achieved through a well-established doctor-patient relationship. The American College of Physicians, in September of 2017, came out with their position paper on the ethics and the legalization of physician-assisted suicide. And the abstract says in part, the American College of Physicians does not support the legalization of physician-assisted suicide. It is problematic given the nature of the patient-physician relationship, affects trust in the relationship and in the profession, and fundamentally alters the medical profession's role in society. The ACP went on to say, society's goal should be to make dying less, not more medical. Physician-assisted suicide is neither therapy nor a solution to difficult questions raised at the end of life. All 5 judges of the New York State Court of Appeals, New York State's highest court, last September joined in the opinion which ruled there is a rational basis for our state law banning physician-assisted suicide. They make it clear that there is an important and logical distinction between a person refusing life-sustaining treatment and a patient obtaining a lethal dose of pills for the purpose of suicide. According to secular culture, the dignity or value of a person is often associated with what that person can contribute. When this is where our dignity comes from, it can change or be taken away. People often argue that they need assisted suicide to preserve their dignity. Human dignity ultimately rests not on a person's interest, but on the value of the person whose interest they are. And the value of the person is infinite. Daniel Sulmazy, MD, reminds us that this intrinsic worth is what was at the heart of the civil rights movement. It does not matter what a person looks like, how productive the person might be, how others view that person, or even how that person may come to view herself. What matters is that everybody, black or white, healthy or sick, is a somebody. Assisted suicide and euthanasia require us to accept that it is a morally permissible act with the specific intention of making a somebody into a nobody, i.e., to make them dead, end quote. For which is morally important, people or their interests? We are not isolated people. What we do affects others, sometimes more than what we think. As a family physician, I had the opportunity to do house calls. Over the last several years, I've been doing home visits on a patient with progressive muscular dystrophy. 20 years ago, when Bob presented to my office, he informed me that all the men in his family had died of this disease, and that he knew what was going to happen. He didn't expect to live more than 4 or 5 years more. As it turned out, I was the recipient of a tremendous gift. For 20 years, I was able to share in his care. He and his wife taught me more about compassion, communication, medicine, and the value of life than I ever learned in medical school. Recently, his wife called and told me that his condition had taken a significant turn for the worse. As I visited him in his home, he thanked me for the care I had given him for 20 years. No heroic measures were done, and he died peacefully at home with his family 2 days later. I refuse to abandon my patients in their time of greatest need. This is the noble profession I entered, and that which I wish to protect. Thank you.